Okay guys, Timmy coming at you here, and today what I'm going to do is I'm going to explain to you the pulmonary function curve, and I'm also going to explain to you why in people with COPD why their pulmonary function changes. And in people with COPD, the bottom line is they can't get air out. They can take air in, but they can't get it out of their lungs. So let's talk about that. First of all, a couple of things you got to know. Number one, when you take a breath in, regardless of whether you have COPD or not, this is the wall of the bronchioles, which is made of muscle, and then you have the vascular lining. So in people with COPD, asthma, bronchitis, there's that inflammation of that vascular lining, right? So basically what's happening is the hole that this little lumen of the bronchioles is getting smaller. But when you take a breath in and you expand your lungs, you also expand the bronchioles. So even though it's inflamed, you can expand the bronchioles and you expand the alveoli and air can get in. The problem is that because of that inflammation of the bronchial lining, and in the case of asthma, bronchospasms and mucus production, that when you blow the breath out, the alveoli tend to collapse and the bronchioles tend to collapse. So they can't get the air out as quickly, and sometimes they can't get the air out at all. So air starts becoming trapped in the alveoli. That helps explain why the residual volume in people with COPD increases, because they're actually getting that hyperinflation, the overinflation of the alveoli. And over time, they will get a barrel chest. Now, when they do a pulmonary function test, what they do is they put a nose clip on so no air escapes through the nose, and then they give you a mouthpiece where you make a good tight seal. And then what they'll do is they will measure the amount of air that you can breathe in and out over a given period of time. So the time is measured in seconds, and the air is measured in liters. So if you put the mouthpiece in here, and then you start breathing normally. So a normal inhalation and exhalation is called tidal volume. So that's the amount of air that you take in and out with a normal resting breath. Then what they're going to do is they're going to ask you, after you take a normal inhalation, to take as big a breath as you can in. And that volume of air that you can take in beyond the normal inspiration, right? That's called your inspiratory reserve volume, or the amount of air that you can take in beyond a normal inspiration. Then what they're going to do is they're going to tell you, after you take that normal inspiration as big as you can, after you take that big breath in, inspiratory reserve volume, then they're going to tell you to blow that air out. And the amount of air that you can blow out beyond a normal expiration, you can see it starts at the normal expiration for a tidal volume. That's called your expiratory reserve volume. And as you can see here, expiratory reserve volume is much greater than inspiratory reserve volume. Then what they look at is what's called forced vital capacity, or vital capacity. And vital capacity is the amount of air that you can take in with a maximal inhalation and then forcefully expire it out. So your forced vital capacity is actually a sum of 3 volumes. It's the sum of your tidal volume plus your inspiratory reserve volume plus your expiratory reserve volume. that equals your forced vital capacity. And you want to force that air out, and I'll explain why in a minute. Now, and remember, in people with COPD, what happens? Their airways become inflamed, especially the smaller airways. So they can get air in, they just have a hard time getting it out. So the amount of time it takes a person with COPD to get a certain amount of air out is going to increase, and that's how they diagnose it. So the other value that they look at when they look at forced vital capacity, or the amount of air that you can take in maximally and blow out maximally, what they do is they look at how much of that air, when you took a huge deep breath in and then blew it out, how much of that air could you get out in the first second? So that's called your forced expiratory volume in the first second. That's where they come up with the term FEV1. So again, in people with COPD, they're not going to be able to get as much air out. So if you look here, how much could this dude blow out in the first second, or totally, his forced vital capacity? Well, he started here and he went up, if these lines are perfect, which they are, of course. That would be 4 liters. So the guy's forced vital capacity is 4 liters. Now what the physician wants to do is they want to look at that, and they want to look at how much of that 4 liters could this guy get out in the first second. Forced expiratory volume in the first second. Well, if you look here, he was able to get out 3 liters of that 4 liters in the first second. So what they look at is this ratio of FEV1 to FVC. And if that ratio is typically less than 75%, that's diagnostic criteria for obstructed airways. Now, let's look at an individual who has COPD, chronic obstructed pulmonary disease. Here's the pulmonary function curve. Here's a person's tidal volume, inspiratory reserve volume, and then you tell him, okay, blow that breath out as hard and as fast as you can. So he's blowing out, boom. So what's the guy's total volume of air he can blow in and out after taking a maximal breath in and then blowing it out? Again, the lines are perfect. So this guy's FVC is 4 liters. Now, let's look at how much of that air, of that 4 liters, could that get out in the first second. So here, you can see that the curve is not as steep. And you can see that from 1 to 2, which is 1 second, he could get out about 2 liters of that total of 4. So what we do is we take the FEV1 divided by the FVC. How much could he get out in the first second? He could get 2 liters out. How much could he get out totally? The FVC, that's 4 liters. So, and you can do the math. So the ratio of FEV1 to FVC is 50%. So this guy has what's referred to as severely obstructed airways. And this is diagnostic criteria for chronic obstructed pulmonary disease. Now, what they will do, especially in people with asthma or even chronic bronchitis, what they will do then is they will give them a beta-2 agonist. And if you remember, beta-2 right? Epinephrine agonists stimulate. And you remember you have beta 2 receptors in the bronchioles. And then what they want to do is they want to see if a medicine that mimics epinephrine, like albuterol, can reverse this obstructed airway. So they'll give them a couple of hits on it. You know, they'll go take big deep breaths, suck it in, hit it, right? And then they'll say, here. And then what they want to do is they want to see if this obstructed airway pattern, that constriction of the bronchioles, could be reversed with albuterol. And oddly enough, it's called a reversibility study. And then they'll repeat the pulmonary function with the hope that the FEV1 is going to increase, meaning because you opened up the airways, this person can get more air out in the first second. Now, people with asthma, they're not always having symptoms. So if a person comes in for a pulmonary function test, what you want to know is, will albuterol, when they are having symptoms, reverse it? So there's a drug that they can administer to a person called methylcholine. You've heard of acetylcholine, right? Acetylcholine parasympathetic, norepinephrine sympathetic. So methylcholine is going to stimulate the parasympathetic nervous system and cause the bronchioles to constrict. So they'll let them inhale methylcholine, and then they'll do the pulmonary function. What's methylcholine going to do to your bronchioles? It's going to cause them to constrict. So it's going to cause the FEV1 to be much lower than it was before. Then they give them the beta 2 agonist. They give them albuterol with the hope that when they repeat the test, the pulmonary function, that the FEV1 is going to go up. So that's the pulmonary function test, and that's how you interpret it. One last thing. I'm sure you probably looked at it in your book, and I'm not coughing because I have COPD. You have TLC, that's tender loving care, which I try to provide for you. That's total lung capacity. So the total lung capacity is your forced vital capacity plus your residual volume. And the residual volume is the amount of air left in your lungs after you forcefully push out all the air that you can with one breath. And as you age, the residual volume goes up. So increased age, increased residual volume. That's why old men look like little babies. They have no hair, no teeth, and they go goo goo gaga, and their chest kind of becomes barrel shaped. And that is due to the increased residual volume, or the amount of airlift in the lungs, and kind of hyperinflating those alveoli. All right, I hope it helped.